Hello, everyone. So thank you for joining us. We'll be starting shortly. You may have some people that trail in the next couple minutes, but I understand that everybody is a little time sensitive across the country here, so I will probably just dive right in. So first and foremost, hello and good evening, everybody. Thank you all for joining us for our second Living with Liver Disease session. My name is Bianca Tatro, and I'm the Regional Coordinator for Manitoba and Saskatchewan of the Canadian Liver Foundation. I would like to start by acknowledging that the Canadian Liver Foundation's national office in Markham, Ontario is situated upon traditional territories of the Anish, and I'm so sorry, I'm gonna say this horribly and I do apologize, and Abi peoples and of the, I'm so sorry, Haudenosaunee Sani peoples. I'm so sorry. I know I've said that incorrectly. I do apologize. Covered by the Upper Canada Treaties. If any of you have any land acknowledgements that you'd like to place in there, please do so in the chat box. The chat box is there for really anything that you feel comfortable with, asking a question, anything like that. But at this time, if there's any land acknowledgements. So the CLF Living with Liver Disease program has been around for more than 25 years, and it continues to serve as an educational tool for both patients and caregivers, but also as a peer support tool. This program provides an opportunity to increase community-based learning about liver disease and the importance of liver health in hopes to reduce the incidence and impact of liver disease through prevention, early diagnosis, treatment, and care without geographical barriers. Speakers include healthcare providers, allied health professionals, subject matter experts, as well as patient advocates. If this is your first time joining in, we do have polls. So the polls, to get a better idea of who our audience members are today and where they're tuning in from, we will open 2 short polls that'll pop up on your screen. So hopefully you can all see them. And once you see those, we ask you to please fill them out. Today's session will address autoimmune liver disease. We are joined by our presenters, Dr. Stephen Wong from the University of Manitoba, as well as Ms. Carol Seaburn. We will have our 2 speakers complete their talks prior to moving to a question and answer portion. Please feel free to use the chat feature at the bottom of the Zoom screen to ask your questions during the presentation, and note that questions will be answered following the speaker's presentation. Following the Q&A, we will be hosting breakout room sessions. This will provide an opportunity for our community members across the country to talk about their journeys openly and safely, share insights, stories, tips, and suggestions with others who may be going through the same thing in their respected local, regional, provincial area. For those who are not familiar with the breakout rooms, it is a feature within the Zoom platform that allows people to be split into smaller groups within the meeting. The groups are split into regions or provinces, and we suggest joining the group that best fits your geographical location. So if you find yourself not sure which group to join, one of our moderators, staff members will assign you to a group. The breakout rooms will be running for 30 minutes. Today's session will be recorded and available on the Canadian Liver Foundation website, which is www.liver.ca, as well as our Facebook and YouTube page in the coming days. In respecting our members' privacy, the breakout room sessions following the talk will not be recorded. For those of you who may not be familiar with the Canadian Liver Foundation, I would like to provide you all with a brief overview of who we are and what we do. The CLF was established in 1969 and was the first organization in the world created to help people with liver disease. We are committed to promoting liver health and improving the prevention, diagnosis, and treatment of liver disease through our 4 core pillars, which are research, education, patient support, and advocacy. At this time, I would like to welcome our first speaker, Dr. Stephen Wong. Dr. Wong is a hepatologist and an associate professor of medicine in the section of hepatology at the University of Manitoba Health Science Centre. He is also the director of hepatology education programs and a director of online learning for undergraduate medical education at the Max Redi College of Medicine. He completed his medical degree, internal medicine residency, and chief medical resident training at the University of Manitoba. His areas of interest are viral hepatitis, fatty liver disease, and medical education. I'm very happy to introduce you all to Dr. Wong.
Well, thank you, Bianca, for that nice introduction, and thank you again for allowing me to participate in your wonderful forums here. And I was tasked today with a talk about autoimmune liver disease, but we're going to focus on primary biliary cholangitis because there's so much to talk about with autoimmune liver disease. There won't be enough time in 30 minutes to try to get it all in. So I'm going to try to pack it in. I apologize in advance. I'm going to have lots of slides. I might be going fast. That's why it's recorded. This is good. You can review it in half speed if you like. I have to say the med students review my stuff in 2 times speed because they're just that good, I guess, or I talk too slow, one of the two. But I'm going to try to turn on my slide and share it here. I'm going to take over the screen. I was having a little trouble with this. Let's see what will happen. Can I take it over, Bianca? Yeah, okay.
Yes,
Let's see how this works. If it shares or it does not share. It hasn't been kind sharing when I did it last time. Let's see. Now, can you see the one full slide?
I can still see the 2 slides.
The 2 slides, why does it keep doing that? Okay, I'm going to stop sharing that again. Try this again. I'm going to put it on this desktop here. Okay, and there, that should be better. Is that better?
Yes.
Yes, all right, we're starting off well with 1 slide. So what we're going to talk about again is autoimmune liver disease, but focusing on a condition you can't see, which is like all liver conditions, you can't see them. And that's why I said focusing and understanding on what you can't see. Now, there's a lot to talk about, but in the end, the gist of it is you're going to learn all the 5 W's: who, what, where, when, why, about liver disease, about primary biliary cholangitis as an example of autoimmune liver disease. You're going to understand what PBC is and what it isn't, how common it is, the epidemiology of primary biliary cholangitis, and a bit of the natural history from start when someone develops it to as it progresses potentially, who's at risk for PBC and why you should be screened for PBC or other liver diseases or your family members, what are some of the symptoms, how is someone who's suspected to have primary biliary cholangitis diagnosed, and where and when should you seek help from medical experts? What are the current therapies and are there other future therapies? And there are some symptoms that are specific to primary biliary cholangitis that people may experience, and there are some different therapeutic interventions that we can use to try to help with the symptoms. So let's move right in to understanding what an autoimmune liver disease is. And in particular, in more general terms, what is an autoimmune disorder? So if you look at the definition of autoimmune disorders from there's so many different definitions. I like this one from the National Institute of Health Medline Plus. An autoimmune disorder occurs when the body's own immune system attacks and destroys healthy body tissue by mistake. And that's the key word here. It's by mistake. In a way, you get confused. There are a lot of different autoimmune disorders. They can be from at the cellular level all the way to organ levels. And that's why it's an important thing from a liver perspective, because the own body's immune system can attack the liver. And one way I like to look at autoimmunity and autoimmune diseases in general is when you think about your own immune system, think about your immune system as an army that is surveying the landscape, and it's trying to determine what should be there and if there's anything foreign, like a radar system. And when it detects something foreign, like a bacteria, a virus, it starts to develop antibodies to try to attack those foreign substances to make you not feel sick. Because for example, if you had a cold, a flu, COVID, the body attacks it and eventually clears it by attaching antibodies to it, and those antibodies get cleared by the white blood cells eventually, and the scavenger cells in the body. And so it works well when things are going well, but on the other hand, with an autoimmune disease, often the immune system gets a little confused, for lack of a better word, or a little mistaken. And this cartoon explains it. It says there's a normal cell right here, everything is going on well, but someone says, hey, that's an intruder, a foreign person or cell, and we should attack that person. And the cartoon cell says, what? But I'm one of you. And the body says, don't listen to her lies, and they attack your own body. And that's part of the whole problem. So it can happen at the cellular level, as we talked about, can also happen at the organ level as well. And this is a funny cartoon I found about autoimmune kidney disease. And you can see from reading the cartoon here that the same thing happens, that the white blood cell is monitoring and says to the autoantibodies, wait a minute, this kidney shouldn't be here. Let's start to take that person out or that organ out, or try to eliminate it. And that's how you start getting damage to that organ. Now, how about with autoimmune liver diseases? What kind of examples do we have here? Well, one of the most common ones and known for a long time is autoimmune hepatitis. And that's where your body's own immune cells start to attack the hepatocytes, or the liver cells here, and cause damage to the hepatocytes. And damage with the liver causes inflammation, and inflammation leads to fibrosis formation or scar formation, which can lead to cirrhosis, which is the ultimate end stage where most of the liver is damaged from scar tissue. Now, another example is primary sclerosing cholangitis, where the own body's immune system starts to attack the large bile ducts. And primary biliary cholangitis, which we're going to focus on today, where the own body starts to attack the small bile ducts within the liver. So let's talk a little bit more about PBC as an example of the autoimmune, as an autoimmune liver disease. So what is PBC? So we use that acronym because we don't want to keep saying primary biliary cholangitis, primary biliary cholangitis. Try to say that 5 times fast. You get tired and you'll just end up saying PBC. So that's why we say it in the medical community. It's just easier to say. Now, what in fact does that mean? It's, again, an autoimmune condition of the bile ducts, which are these green sort of branch-like structures in the liver, where the liver makes bile, which is a liquid substance that gets secreted into the bile ducts. The liquid bile goes all the way down into the bowel, so it helps you digest fat in the foods you're eating. And when all is going well, if you look at the slide on the right here, the picture on the right, things go well, and the bile flows nicely through to the bowel, helps you digest the fat in the food you're eating, all is well. When you have the autoimmune condition, and your own autoantibodies start to destroy the bile ducts, it starts to get damaged. Kind of looks like, a plug drain or something that is a hose. Have you ever had a kink in your hose? Now we're getting into the spring season. I was trying to water the garden the other day. I'm like, why is it not, the water not coming out? No, you got a kink in the hose. So it's kind of like that with bile ducts. Bile doesn't flow well, and it starts to have problems with cholestasis, and some biliary endothelial cells will get damaged, and the toxic bile acids will leach out and cause fibrosis. And that's not what we want to see. But that's how it can develop. Now, if we look at things from under the microscope, if you had a liver biopsy, it would kind of look a little like this. So this is what we look at under the microscope of the histology of a liver, the liver architecture. And so on the picture on the left here, the pink cord-like cells here are liver hepatocytes. And the liver is arranged nicely into this organization where you have what we call the portal triad here, which is a portal vein. You have a hepatic artery, and this is a bile duct. And they're kind of grouped all together. On this picture, it's right over here in this cartoon. And things kind of flow from here all the way to the central vein over there when things are going well. Now, what happens when you have bile duct irritation from damage from the autoantibodies that cause primary biliary cholangitis? Well, the liver enzymes that are made in the biliary cells here, one of the main ones is alkaline phosphatase, or for short we call it ALP, and we'll talk definitely more about that coming up. Instead of it being made here and secreted into the bile a little bit and into the bloodstream in low levels, the biliary cells get damaged, and it causes the bile cell or the biliary endothelial cells to start to have inflammation, starts to leach some of the alkaline phosphatase, and it actually gets deposited into the bloodstream in larger and higher levels than normal. And that's one of the ways we can detect something is going on in the biliary system, is by looking at the alkaline phosphatase or ALK-Phos level. So we'll come back to that in a little bit because that's part of the screening and the diagnosis of PBC. Now, when the biliary cells in this picture, these little look like sunflowers, when they get damaged by the inflammation from the autoantibody attack, it activates collagen formation or liver fibrosis to develop, and it starts to cause, as I showed in the other picture before, the strictures in the bile ducts, and the bile doesn't flow well, and it starts to cause more problems with the toxic bile acids and salts that should be getting into the bowel, but they're now leaching out and damaging the liver itself. So that's, in a nutshell, how primary biliary cholangitis occurs at the microscopic level. So now that you know that, I just want to stop for a second and make sure we know what PBC is not. So PBC should not be confused with PBS. So I can't see any of you. Somehow with my screens I can't see you. So I hope you're still there. If there is someone, if somehow I get disconnected and I'm just talking to myself, Bianca, just pipe in with your microphone. You have to turn your mic on and let me know, because I actually can't see anyone now. But anyways, PBS, we all know, is the public broadcasting system. Great shows, great educational programs, definitely not PBC. The other thing not to be confused about with PBC is it is not PSC. That's the other autoimmune liver condition I was mentioning earlier, where the autoantibodies attack the large bile ducts of the liver, and that can lead to cirrhosis. PBC is an attack of the smaller bile ducts within the liver, which again can lead to cirrhosis, but they're different. PSC affects more men, and usually men who have an inflammatory bowel disease or colitis. PBC, you'll learn today, affects more women, significantly more women. So they are quite different autoimmune liver conditions. And then the last thing to not confuse PBC with is the old terminology, primary biliary cirrhosis. So when I was in med school, we always called it primary biliary cirrhosis, PBC. And in the last half a decade, everyone started realizing, why are we calling it primary biliary cirrhosis? Because not everyone develops cirrhosis, and it makes everyone feel like you have end-stage significant scar tissue damage in the liver, cirrhosis, when you may not. And so someone was smart and said, why don't we change it to primary cholangitis, biliary cholangitis, and we'll keep the PBC, but now we won't be telling everyone you have cirrhosis. But cholangitis is an inflammation of the cholangiocytes, which is the biliary cells in the liver. So that's actually more of an accurate description of what's going on in the liver. It's inflammation, which is the itis part of cholangitis, of the biliary system, or the bile duct cells, which is the cholangiocytes. That is the main problem, and it doesn't always lead to cirrhosis in everyone. And so people used to say, well, I thought I had cirrhosis because it's in the name, but it's actually was originally made to, or called that because it could lead to cirrhosis, but again, not everyone it does. So let's look a little bit about how common this is. That's the epidemiology and then the natural history from when someone has PBC and what happens thereafter. So how common is it? Well, as I was mentioning before, it's very common in women. 90% of women compared to 10% of men are affected, and it's usually women over 40, and it's 1 in 1,000 women over the age of 40 may be affected by PBC. There's a lot of different age ranges. You can be in the early 20s all the way up to 80 or so. So it's a wide range, but the majority of people in their third to fourth decade often will start to present with the potential diagnosis. Now, PBC varies with each individual, and there are some people that it is a little more aggressive, especially in men, and it's more aggressive in people who don't respond to one of the treatments, which is ursodiol or ursodeoxycholic acid, which we'll talk about later on in the treatment. So it does affect people very differently. And PBC is associated with other autoimmune liver conditions and potentially some other environmental risk factors, but it's not completely clear how these are all associated, but there are some associations with other conditions. Now, we know it affects everyone across the country, and it's more common certainly in North America and Europe. We don't have a lot of good studies in Canada alone, but this was one from Dr. Yoshida in BC. They collected some data across the provinces, and the key here, since I saw earlier on when Bianca asked the question, we have a wide-ranging audience across the country. It basically can affect anyone across the country. Now, it's a little more common in the prairie provinces and the Maritimes, and it's often thought in our prairie provinces here we have a higher risk of autoimmune diseases. We're not sure why that is. If it's the radon and the gas in the ground, or what is it? But there is a little higher prevalence of autoimmunity and autoimmune diseases in the prairies. And so that could be one of the reasons why we see a little more PBC here. But it's not that far off compared to everywhere else in the country, and it definitely goes throughout the country and not certainly sparing a certain area. Now, when we look at what happens when you develop PBC, what ends up happening initially is nothing. In other words, nothing happens. You feel asymptomatic. You might have some markers that look like you have the condition, but you may not have any active inflammation in the liver and any active damage to the bile duct cells at that time. But at some point, in some people, it starts to have the immune system starts to attack the bile ducts, as I was mentioning before, causing damage. Some of the bile salts and acids get stuck in those bile ducts. The bile ducts actually start to get destroyed, which is also hampered by the fibrous tissue forming around the bile ducts. And when that happens significantly throughout most of the liver, that's what we term cirrhosis. And you can feel completely fine all the way up to this point in time. And I always tell my patients and our residents and learners that I always say the liver is a very strong organ. It will keep on working hard, even though it's getting attacked and damaged, until it basically says, I can't do it anymore. And when that happens, that's when you develop decompensated cirrhosis. And at that point, you start getting a whole variety of potential symptoms, which is not a good sign. You can become jaundiced. This is a person who's got personality changes from hepatic encephalopathy, confusion. You can develop large blood vessels up the bottom of the esophagus called esophageal varices that are at risk of bleeding. This is not a pregnant woman. This is a man who has ascites, which is a large amount of fluid buildup in the abdomen, which is a sign of portal hypertension, which is high pressure in the veins around the liver. That leads to leakage of fluid in the belly. It puts you at high risk for liver cancer or hepatocellular carcinoma. And these people at that point, sometimes the only treatment is a liver transplant if you're eligible. So the goal is to try to avoid getting up to this point in the natural history, because with early intervention with the treatments, they can slow down the progression. And with good monitoring, we can hopefully prevent people getting to this point. But some do, but the majority now, especially with some treatments, we can reduce that risk. Now, who is at risk for PBC and what are some of the symptoms? As I mentioned, that the majority of people who are affected by PBC are women. So over 90% of patients with PBC are women, 10% are men. And again, it's a wide age range of women, 35 to 60 to 80. There are some genetic predispositions. There's no specific one genetic abnormality that you can screen for or do a test on that says you're at risk for it. And that's where We know it can run in families, but it's not something that we can do genetic testing on to determine if you or your family members are at risk for it. Now, PBC is often associated with other autoimmune diseases, and one of the dogmas of teaching in medicine is that if you have one autoimmune condition, you're at higher risk for others, which kind of makes sense because your immune system, again, is a little confused. It starts attacking, say, your red blood cells, and that causes autoimmune hemolysis, and it attacks your platelets, it causes autoimmune thrombocytopenia, attacks your joints, that could be rheumatoid arthritis, and attacks your liver, and there's primary biliary cholangitis. So it can affect a lot of different parts of the body. These are some of the other common autoimmune conditions associated with primary biliary cholangitis, but there's a whole host of them. One of the more common ones is thyroid disorder as well. So it's something that we look at because fatigue is an issue with people with some people with primary biliary cholangitis, and that can also just be related to the onset of a thyroid problem. So we always want to make sure that's not part of the problem. So what are the signs and the symptoms? And I highlight often most people have no symptoms until they have significant damage to the liver and they have decompensation. And it can be like that for over 10 years. But if you do have symptoms, the top two symptoms that many people get with primary biliary cholangitis is extreme fatigue. And so people have been pretty good at knowing their bodies and have come and said in my clinic, I was doing great. I was doing jogging. I could do, 5 miles a day, and then I couldn't do more than 4. And then eventually I couldn't do more than 2. And nothing else has changed. I'm eating well, I'm sleeping well, nothing's changed. And I don't have the energy anymore. And so it's quite dramatic in some people that they notice things and their exercise tolerance and their energy levels going down significantly. So that's one of the most common things, but it's very non-specific. It's a non-specific symptom. So as I was mentioning before, thyroid disorders can cause fatigue, especially if your thyroid hormone levels are low or if you have hypothyroidism and if you're not getting good sleep. So there's a lot of reasons why you can develop fatigue, and it's important to make sure those aren't contributing. But primary biliary cholangitis, in the absence of anything else, can by itself cause fatigue. And it makes a bit of sense because if you have this ongoing sort of battle going on between your immune system and your bile duct cells, it's kind of like you've got, the way I like to describe it is like you've got an ongoing chronic flu or cold going on. So it makes you feel a little drained all the time. So that's one of the number one symptoms people will get if they do have symptoms. The other is itching, and it can be very specific type of itching. And we teach our medical learners that there's not many conditions that will cause significant itching in the palms of your hands and in the soles of your feet. It's very different. Some people, you get dry skin and you're scratching your arm or your back, but not many people scratch the palms of their hands. That's why it's if you're paying attention as a physician or a healthcare provider, you can actually start to pick up these people that might have a chronic liver disease like PBC based on that one symptom alone. As well, the itching is worse at night, and it's often worse overnight. So people are fine. Sometimes during the day it's manageable. You go to bed and then they keep waking up in the night with this really severe itch. That's in the palms of their soles or palms of their hands and soles of their feet. So it's again, if you're paying attention, you can start to determine if someone is at risk or developing symptoms that could suggest they have primary biliary cholangitis. Some people develop a little abdominal pain, and it's not general abdominal pain, it's just specifically around the right upper quadrant under the rib cage where your liver is, because as the liver has that inflammation and swelling, then that can also cause some generalized discomfort. It's not attacks like gallstone attacks or what we call biliary colic. It's where that type of pain is where it's very severe and significant. This type of pain is it's constant. It's just not comfortable. Now, if you get yellowing of the eyes or what we call sclerosis or of the yellowing of the skin or jaundice, that's more when you develop more significant liver damage. And some people get dry eyes and throat or what we call sicca symptoms that can be associated with PBC. So there are a few unique symptoms that we need to be aware of that people with PBC may present with. And I just wanted to highlight again, but most are asymptomatic. Now, these two pictures here are just two of the things that I want to point out. These are extreme images because it's not usually like this. These are what we call xanthomas or xanthelasmas, which are sort of fat and cholesterol deposits around the eyelids, which are what called xanthelasma. And you can actually, when you're again being attentive, you can see these in some patients, and that's often a sign of PBC. It can be a sign of cholesterol issues as well, like high cholesterol issues otherwise, but it is a finding that's unique to PBC as well. And it can happen in the joints or the extensor surfaces, we call it, and the folds of the hands as well. But it's not usually this obvious. But these were good example pictures just to give you a sense of what that is. Now, how do we diagnose PBC? Well, in liver disease, we often will say that it's very hard to make a diagnosis of many liver conditions, and you have to somewhat be a detective and put blood work together with the physical symptoms and the history of the symptoms and kind of rule out these conditions and try to figure out what would be the most likely cause of or what would be the likely cause in the diagnosis of a liver condition for most liver diseases. PBC is the one fortunate thing with it is it's one of the few liver conditions that has a very good blood test that is very sensitive, very specific for the diagnosis of PBC. And that is this anti-mitochondria antibody that when it's high, over 90 to 95% of people will that will suggest that they have primary biliary cholangitis. And so we want to see that being positive to suggest that they have PBC, as well as that enzyme. Remember, we talked about that enzyme ALK Phos that is made in the biliary endothelial cells. When it's higher than normal because the bile duct cells are getting irritated and releasing more ALK Phos into the blood, we can detect it at higher levels. Along with the AMA, those are usually two main criteria that we need to diagnose primary biliary cholangitis. We used to do biopsies a lot more, but knowing how accurate this is, and when you add in the ALK Phos along with it, and we've ruled out other liver conditions, we really don't need to do a liver biopsy for most people with PBC. So usually through blood testing alone, we can be pretty confident with the diagnosis of PBC. Now, as I mentioned here, that over 90% of people with PBC have a positive AMA. And so once it's highly positive, then there's a high index of suspicion that you have that condition. Now, often other things are done to try to rule out other liver conditions. One of the most common is abdominal ultrasound, which is actually a part of a routine assessment for a liver patient. And we want to make sure that there isn't any problems with the bile flow. And we can tell that through ultrasound, looking at their bile ducts, or making sure there isn't another liver condition like gallstone disease that could also look very similar to PBC minus the anti-mitochondrial antibody positive test. Some people order MRIs or these magnetic resonance cholangiopancreatography or ERCP, which is the scope version of it. We don't need to do that for diagnosing PBC. One of the newer things that we like to do are non-invasive tests of liver fibrosis to determine how much scarring has been done to the liver at this point in time. Because you might recall I said earlier that patients and people with PBC will feel completely fine, asymptomatic, but could be having damage to the liver at some point in time. And we don't know when the condition started, so we like to do tests. One of the most common ones available now is called transient elastography or a FibroScan, which is this machine here. And it's a simple ultrasound-based test that we can use to determine how much scar tissue is present in the liver. It gives us a little assessment of the fat in the liver as well. So it's good to have an idea of how much potential damage has been done to the liver to that point in time. So it doesn't diagnose PBC, but it's a nice adjunctive to know whereabouts in the natural history of PBC you're at. So when and where should I seek help from medical experts? Well, definitely if you have a history of autoimmune liver diseases in your family or PBC, you should be having your liver enzymes and ALK Phos checked. And if they are persistently elevated, not a blip up and down, but persistently, meaning above the normal ranges for more than 6 months and there isn't a reason for it, or if you have symptoms, we talked about the itching, the fatigue, abdominal discomfort, or symptoms of advanced liver disease, then you definitely need to be seen by a liver specialist, and your family doctor or primary care provider can refer you to hepatology or GI to make a further assessment. Now let's quickly move on to the treatment for PBC. And I'm going to go through this a little bit faster in the interest of time. Am I doing okay with time, Bianca? Are you still there, or am I talking to myself?
No, you're good.
Okay, good, thank you. So one of the first line medications that is used universally for PBC is ursodeoxycholic acid, or Ursodiol, or we call for short UDCA. And it's been around since the 90s, and it's been the standard therapy and the backbone of treatment for PBC for a long time. And it's not exactly clear how it works. It's a natural bile salt that is in higher concentration, and it has some properties to improve bile flow. It's anti-inflammatory properties. It adjusts the immune system a little bit in the bile ducts so they're not as damaged. And there's clear evidence that if you use 13 to 50 milligrams per kilogram per day of the Ursodiol, that you can have improved survival and reduce time to needing a transplant, or to reduce progression of your liver disease over up to 15 years. So it's a good therapy that works for many people, but 20 to 40% of people may not respond completely. And that's where we were, up until the last 5 years, we didn't have another treatment option. And I'll come to that in a sec. Now, just to give a little bit of information about some of the studies that were done, the Canadian study in PBC done in the 90s by Dr. Heathcote showed how bilirubin, which is a marker of advanced liver disease, but also a marker of progression to advanced disease and bad prognosis, when they used Ursodiol compared to placebo, which is the gray line, Ursodiol is the brown line, the bilirubin levels improved, showing that it was improving the liver's function and potentially the decreasing the progression of the liver disease. And it improved bilirubin, the liver enzymes, including ALK Phos, significantly more than placebo. And there was an improvement in survival. So the Ursodiol group, there's more people who are doing better, which is this orange line, being higher up here than the people who weren't on any Ursodiol treatment at all. And then looking at the people who went on to transplant, again, the people who are on Ursodiol got off this bad curve, needing more, which is showing more progression to liver disease and higher need for transplantation. The people who are on Ursodiol, kind of the curve flattened out, which was again a sign that it's improving survival and decreasing progression. And so then, as I mentioned earlier, we're coming up to obeticholic acid, or OCA, or now the brand name is Ocaliva. We're glad to have another drug in our armamentarium to treat PBC, which has only been around for, again, the last 5 years or so. And it works in a different way than the Ursodiol. It's a farnesenoid X receptor agonist, which is 100 times more potent than one of the natural bile acids that our body makes itself. And in short, it helps improve the bile flow, reduce the synthesis of bile acids, and helps reduce inflammation, helps reduce a little bit of fibrosis development as well. And just as a quick review of one of the main landmark trials, which was called the POISE trial, was reported in the New England Journal in 2016, that the people who were on the obeticholic acid, a number of them had improvements in their ALK Phos more so than people who weren't. And so it's 10% of people who weren't on it had improvement in their alkaline phosphatase versus 46 to 47% did. And these are people who also were on Ursodiol, because obeticholic acid is used in addition to Ursodiol for the majority of patients. And then bilirubin also improved, as I mentioned with the Ursodiol in the previous slides. But one of the problems that obeticholic acid has is that it can increase risk. It increases the risk and the side effect of itching or pruritus. And so, as I mentioned earlier, a lot of people with PBC have pruritus or itch as a symptom, and to have it get worse when they're on this drug that's supposed to make things better is a challenge. And so it's one of the things that if you don't get this side effect of itching, you're doing great. If you do, it might not be the thing for you. And that's why there are newer agents being looked at to see if they can avoid that side effect. So in the end, when we do treatments and get to the point of reviewing therapies with a newly diagnosed person with PBC, we always start with ursodiol, see if there's been a response, meaning the alkaline phosphatase level is decreased significantly. Ideally, we want to see it return to the normal levels. And if it does, we keep going and with just the ursodiol monotherapy. If it doesn't, we can add in low dose obeticholic acid. If it works, great. If it doesn't, we can increase it to the other higher dose formulation, which is 10 milligrams. And if it works, fantastic. And again, if they don't have the itching side effect, that's fantastic. If it doesn't work, there are clinical trials in various cities. A number of the sites in Canada are participating in these PBC clinical trials, looking at newer experimental agents that might be of use. And if you don't have that option at the time, or the person doesn't qualify, one third option that's been more, it's been in the background for a while, and it's been more a favor lately, and it's been more endorsed by the National American Association for the Study of Liver Disease guidelines, and they updated it last year, is the use of fibrates. Now, fibrates are a class of medication to lower cholesterol, but it does have some improvements in the bile itself, and can improve the alkaline phosphatase levels in people with PBC when it's used in addition to ursodiol. And so that is one thing that it's considered off-label use because it's not really indicated for that, but it has been used successfully in various studies. And I've used that in some patients, and it's helped improve the control of their PBC. What about some of the future treatments now? So those are the current therapies. Well, combination therapy is becoming the norm for a lot of liver conditions and a lot of different health conditions in general. And so there is a study even last year looking at combining ursodiol, obeticholic acid, and fibrates, which might actually help improve the control of the condition, improve the alkaline phosphatase even better than those alone. So that data is new and still needing to be validated, but it's encouraging that there is some more options even with those three drugs that we still have available at the present time. Moving forward, if those aren't an option, I just want to list this table just to show you quickly that there are a lot of companies that are looking or that are actively involved in the next generation agents for PBC, and a lot of them use different or have different mechanisms of action. Some of them are to treat the itching problem with PBC, and others are to see what you can do to improve the response rates of improving alkaline phosphatase, improving survival, and reducing the time to transplantation when ursodiol doesn't work. So looking at more second-line agents, and there are a lot of different ones. And there are also some antifibrotic agents now, which are ones that are trying to reduce the amount of scarring that is forming or reducing the speed of fibrosis development. So there's a lot of things that are being looked at, which is encouraging, and a lot of data is always coming out every year with new results of these agents. So we're looking forward to seeing which ones make it to the finish line and show a good response. And if you want another site to look at for good information, the Canadian PBC Society, which is a well-organized group, lists different clinical trials taking place in Canada. And so on their website is a great place to look for different agents and sites that are doing new trials. Now I want to quickly get into managing the symptoms of PBC. I think we're getting on with the time here. And so I'll just quickly go through that. As I mentioned, fatigue is a very common symptom that many patients with PBC experience. The sad part about that is even if we make sure there's no other cause of fatigue like thyroid issues, there really isn't any treatment medically to help with that fatigue. It's very difficult. I work a lot with patients on just improving their health in general with better diets and good activity levels and exercise, and that helps. There's been different trials looking at stimulants and things, but nothing has really rang the bell as a good drug that might help improve the fatigue of people who have this severe issue with PBC. So that's still out there. With the pruritus, again, mentioning a number of people do have this pruritus, there is a lot of different therapies that are available to date. And we often will start with one. This is a bile acid sequestrant. It sort of is like a sponge that collects all of the bile acid that the liver makes in the intestine, and then you poop it out, and it helps reduce the bile acids being deposited in the skin, which is what causes a lot of the itch. There's an antibiotic, rifampin, that helps as well. Some opioid antagonists like naltrexone, some SSRIs with antidepressant, anti-anxiety medications that have some effects on itch, so it's not great. And then in the end, if it's really bad and your liver is having trouble, then transplantation becomes the only viable option to improve those symptoms. Another symptom that people with PBC often experience is that they're at higher risk of osteoporosis. And so it's important that they get regular bone density testing done, that they have an adequate amount of calcium and vitamin D in their diet, because often people with PBC are vitamin D deficient, which affects the bone health as well. So you want to make sure that's not an issue. And then the Sicca syndrome, which is dry eyes and dry mouth, are difficult to manage, but there are some medications that might actually improve, aside from the conservative things like having a hard candy, gum, that might also help improve those symptoms. Now, how do we monitor people who are on PBC? Most important, you got to check in with your doctor all the time, have regular blood tests, discuss the treatment options. How are things going? Is the treatment working adequately, or do we need to change gears? And maintaining a healthy lifestyle to avoid other liver conditions like fatty liver disease, which there's no saying that you can't have two liver conditions, unfortunately, but that will accelerate the damage to your liver significantly. So you don't want to develop another liver condition if you can avoid it by just maintaining a healthy lifestyle. And if you want more information, here's a plug for the Liver Foundation, which does a great job with advocacy and patient education information. They have a nice brochure that they made with that was endorsed by the European Association for the Study of the Liver for guidance for how to manage your condition and how to understand it. And also, they emphasize that it's important to keep getting your ALK Phos checked, which, if you look at this closer, it's important to try to, this is the marker that tells us that there's less inflammation going on in the liver if the ALK Phos returns to the normal range, which is the ultimate surrogate goal of treatment. And it's important to get it done frequently to know how things are going, because as I mentioned before, 20 to 40% of people may not respond to the current therapies, especially ursodiol, and that puts them at risk of more progression of the scar tissue forming in the liver and cirrhosis. So in summary, this was a whirlwind tour of PBC, focusing and understanding what you can't see, this liver condition you can't see. But I wanted everyone to remember that it is a chronic condition that affects mostly women age over 40, but it's a condition that can progress to cirrhosis, but can be controlled with our current therapies. And most people with PBC are asymptomatic. They don't know they have it, but some may have those symptoms of fatigue, pruritus, osteoporosis, the Sicca symptoms. There are some treatments that might help with those, and that's why it's important to keep checking in with your hepatologist. There's simple blood tests you can do to help with the diagnosis. The ALK Phos and antimitochondrial antibody tests are very helpful. And the ursodiol therapy is the first-line therapy that has been used for decades and is very effective for a majority of patients. And if it doesn't work, we're happy that we have another drug, the obeticholic acid or Ocaliva, to help with improving therapies. And there is more hope to come because there's lots of future therapies and ongoing phase 2 and 3 clinical trials that are looking at newer generations that affect different parts of the pathophysiology and the mechanism of action of the damage caused by the autoantibodies and PBC. And so ultimately, if people are understanding more about PBC, if they see their doctors, they get screened, they find out early that they have PBC and are treated early, that's one of the ways that you can actually keep your liver healthy. And as James Brown said in the immortal words, wow, I feel good. You're going to feel good and keep your liver feeling good for a long time. So thanks a lot for your attention. I hope everyone's still there. And I'm happy to take any questions now or at the end, or however Bianca would like to do it. So thanks, everyone. I'll stop sharing my screen here so I can see people, see how many people fell asleep. Oh, Bianca didn't fall asleep. That's good.
Never. I have kids. There's no such thing as sleeping, right?
That's true. Oh,
Yes.
don't we know it?
So first and foremost, thank you very much, Dr. Wong, for your
My pleasure.
presentation, everything you had to share. I always say there's never enough knowledge when it comes to liver disease. It's forever changing, it feels like. So I'm very grateful for what I was able to take away from today. Meantime, I am going to open everything up for a bit of Q&A until I can get Carol's technology sorted. So if anybody has any questions that they would like to ask Dr. Wong, or maybe others in the chat in regards to NIM or other CLF staff members and representatives have answers to, I'm going to ask that you please post your questions in the chat box, which should be in the bottom of your screens. And Nem, if you don't mind reading out those questions for Dr. Wong, and I, in the meantime, will fix our technical issues over here.
Sure, not a problem.
Thank you.
I guess one of the main questions, I know you kind of covered PBC primarily, and I know at the Liver Foundation, we get quite a bit of inquiries, or at least questions from folks who may have probably both either autoimmune hepatitis along with PBC or somewhere on the spectrum. And I guess it's been argued whether this overlap syndrome, I guess is the term that the individuals use, is the correct terminology, or if it's more along a spectrum where you may have one and it slowly develops into the other. I guess from a patient perspective, would they be able to understand, kind of distinguish between one or the other, let's say in this case, autoimmune hepatitis and PBC? And would they expect to be screened for both over a long period of time, especially if perhaps they were diagnosed at an earlier age? Or any kind of comment along that overlap kind of syndrome perspective?
No, those are great questions. And the short answer is there are two separate conditions, autoimmune hepatitis and primary biliary cholangitis. We often used to call it overlap, and when we think of overlap, it's like, okay, they occur at the same time in one person. But you're right in saying that there are some people that start with one condition, like autoimmune hepatitis, and it changes into primary biliary cholangitis over time, or vice versa. And so there isn't an overlap, it's a continuum of one condition, but it changes over time. Now, from a patient perspective, you may not notice any difference, other than, for instance, if, say, your PBC was well controlled, say on ursodiol therapy, and then suddenly you start getting more symptoms that you never had before come back, like the fatigue gets worse, or you're getting this discomfort in the right side, then that can be a sign that something else is changing. From a medical perspective, it's important that you have these regular checkups with people who have chronic liver diseases so we can repeat their liver enzymes and tests, because that's when we can really tell things are changing. Because the autoimmune hepatitis affects more of a different category of liver enzymes, the hepatocellular ones, or the ALT, AST, more so than the PBC conditions or cholestatic conditions affect more the ALK Phos and GGT. So we can sometimes see a slight change. And I've seen that in some patients where they're doing great with their PBC and their ALT or ALK Phos, sorry, the ALP or ALK Phos goes down. And then over time, the ALT increases. And that can be a sign that autoimmune hepatitis is developing. So I think in the end, they can be separate conditions, or they can morph one into the other. And there are those people that actually it changes over time, and there is that little bit of overlap. So it starts to change at the same time. So the key here is that people may not notice any difference. If they do see a change in symptoms, they should see their physician and talk about it with them. And from a medical perspective, they need the physicians and the liver specialists need to keep checking their blood tests to ensure that everything is as you expect. And when the pattern changes, that's when you need to go looking to make sure there isn't another condition because PBC, as you rightfully said, can have other variants that can develop over time.
Oh, thank you for that. We have one question for participants here with respect to FibroScan and how reliable the FibroScan is, and does a person's exterior body fat or body composition make a difference in terms of results or reliability?
So that's a good question. So FibroScan in itself is a good way to look at liver fibrosis. It's been validated in people with PBC, not as well validated as people with viral hepatitis or fatty liver disease, but it is valid, so we can get a sense of, are you at risk of a lot of scarring or fibrosis in the liver or not? So it's a good technology that we can use, and it avoids a liver biopsy. So I've had patients who, in the earlier days, we would do a liver biopsy to determine how much scarring was in the liver. We got the FibroScan. They don't ever want to go back to having a liver biopsy again, because it's so much easier to do an ultrasound-like exam with the FibroScan probe without having a needle and going into a hospital. So FibroScan by far is preferred because it's simpler. Now, we say it's not as accurate as the liver biopsy ultimately, because the liver biopsy is still what we consider the gold standard in many situations. But it depends. But if the FibroScan is done well, then you can actually be pretty confident in the results. Now, the person asking the question, Suzanne, said a good point, is does the person's exterior body fat make a difference in the results? It does, potentially, because you have to, the FibroScan sends a pulse and it has to get so deep into the liver for it to have an accurate reading. Now, they have gotten a little fancier with the FibroScan, and they have newer probes that can have the wave go a little further into the liver. But there are some people it just doesn't work as well. And when it's not working as well, that limits the results, and the results may not be as accurate. So in those that it works well, great, it can avoid the liver biopsy. Those it doesn't, well, then we need to look at other ways to determine how much fibrosis or scarring or damage there is in the liver. Now, liver biopsy again is one option, but now we have other things that are possible in various cities. There's shear wave elastography, which is available in different areas. I know it's quite widely available in Alberta. In Manitoba, we are always behind. We just got it. And it is an add-on to a regular ultrasound machine, and it works like a FibroScan, and they can find an area that looks a little bit easier to assess to do the fibrosis assessment. And then there's magnetic resonance elastography, which is another thing that can be done through the MRI machine to look at the amount of scarring in the liver. So there are other options, even if the FibroScan doesn't work, because there might be a little bit of extra exterior padding, as I like to say it, that makes the FibroScan not as accurate.
Great, thank you for that. We have one question, probably a pretty common one in terms of liver transplantation. What are the indications, I guess, for liver transplantations for PBC, or perhaps some of the other common autoimmune liver diseases, whether it's autoimmune hepatitis or primary sclerosing cholangitis, or any of the three?
So for all indications for liver transplantation, whether it's PBC or PSC or autoimmune hepatitis or hep C, what we look for is your liver functioning still? Is it doing what it's supposed to do every day? And you're not having any significant symptoms because your liver is still functioning well. And we can tell that a little bit through the blood tests and the liver function tests. But when the liver is not doing well and having trouble, and in those pictures I showed in the natural history of PBC, if you're developing ascites, which is a sign you've got extra high blood pressure in the blood vessels around the liver and in the abdomen, you start building up and accumulating fluid, then that's a sign that the liver is not working as well. If you're having problems with the blood vessels at the bottom of the esophagus getting enlarged, that's what we call esophageal varices. They can rupture and bleed. That means you have more problems than just your liver, and you have a potential risk of mortality and sickness from a significant bleed if those blood vessels rupture. And if you're having problems with confusion or hepatic encephalopathy, that's another sign the liver is not detoxifying the liver or the body and the blood as well. And all those things are signs that now your liver is struggling, and that's when you need to be referred to a liver transplant clinic so that they can start to do some assessments and determine, how advanced you are. Are there things we can do to try to improve those symptoms? Or are you at the point where you need to consider other alternative options like a liver transplant? So it's the same for PBC and hepatitis C and all the other liver conditions, that if the liver is functioning well, great. When it's starting to struggle and you're having those complications of cirrhosis, then we say that's a time when you need to see a liver transplant clinic and specialist.
Right. I will take one more question here, final one. Marianne had a question in terms of PBC and NASH, having both conditions, responding well to URSO, and was able to reverse NASH. So well done there, Marianne. And I guess wondering kind of long-term in terms of cirrhosis or scarring, kind of progression-wise in terms of follow-up. I guess generally, what are the chances of being able to prevent the cirrhosis from kicking in or scarring to happen sooner rather than later?
So that's a good question, and good job to Marianne, because in my slide I was saying, what can you do to monitor your liver condition? I said, keep your liver healthy, and you can have multiple liver conditions. And so just because you have a autoimmune or inherited liver condition like PBC doesn't mean you can't develop other conditions like alcoholic liver disease, fatty liver disease, so many other things. And it's important that when you do find out you have more than one liver condition, you do all you can to improve that condition to avoid more scarring or damage happening to the liver faster. And so that's great, Marianne, that you improved and got rid of had the NASH go into remission. And if your liver enzymes and function tests are all normal, and the PBC is well controlled, there's a lot of good evidence now that suggests that the scarring in the liver can actually regress. And I see it all the time. And when I was a medical student in the 90s, the dogma back then was a scar is a scar is a scar. And if you have cirrhosis, it's going to always be there, and you're basically hooped. That's completely changed. And though a lot of physicians don't know that now, and the literature would support that, if you control the underlying liver condition and let the liver heal, I always say, and give it rest by having normal liver enzymes for multiple years. Remember, the liver is the only internal organ that can regenerate. It can actually regenerate, and if you have enough healthy liver cells left, some of the scar tissue can regress. And since we've got FibroScan now, I've seen it multiple times over and over where someone had cirrhosis, and over the years, things are getting better, things are getting better, things are getting better. So there is hope that if you are maintaining or improving the health of your liver as much as possible, controlling all of the liver conditions you have, your liver cirrhosis can actually regress and improve over time.
Great, thank you. Thank you for those questions. What we'll do, sadly, we weren't able to get a hold of Carol, but I'm sure we'll be able to connect with her in the future and be able to grasp her story. She definitely has a very deep and insightful story as with her journey with PBC, and actually to the point where she wasn't requiring or needing a liver transplant, whereas most people in some of her situation may actually require a transplant, especially as Dr. Wong was saying, if it's caught in a later stage or later in life. So what we'll do, I'll get Bianca to kind of check in on the next kind of breakout room, but I'll just quickly cover the upcoming sessions that we have for those folks who are joining us today and those who are going to be watching this recording live. We do have our session coming up in a few weeks with coping with liver disease. It's June 7th, and then every other month we have different topics covering viral hepatitis, working our way with children's liver disease, September, and then going through liver cancer and tumors, and of course a very common inquiry with navigating the healthcare system as one of our final one. And there's a link in the bottom there, registering at theliver.ca/LWLD for future sessions. So we'll tune into the breakout room shortly. I'll just get Bianca kind of take over here to explain quickly what it is, and then we'll launch them, and we'll go for about a 20-minute discussion.
Again, thank you very much, Dr. Wong. And Carol, if you can still hear us, I agree with them. What you have to say is extremely insightful, and maybe you and I can set something up that we can record what you have to say and we can share it. So if you can hear me, don't worry, I will be in touch with you. Thank you, Nem, for helping me out there. So with that final answer, that concludes our educational session for this evening. I would like to take this time to thank our speaker, Dr. Wong, and thank you, Carol, for your efforts there, for your great talks. As mentioned, this session will be available on the CLF website, Facebook page, and YouTube channel over the next few days. NEM has already gone into our next available sessions that will be coming up. And if you have any questions, just make sure that you look at our website, which is www.liver.ca, Living with Liver Disease, and you'll be able to find everything there as we update. So we'll now be going into our breakout rooms. At the bottom of your screen, you'll see a button that says breakout rooms. Please click the button. And give it a few seconds before you see the different groups available. The groups will be split into regions or provinces. Some will be grouped together depending on how many attendees we have. Once again, we'd suggest joining the group that best fits your geographical location. We will have our wonderful CLF staff and volunteers across the country moderating the breakout rooms. So bear with us for a few seconds as we get the room set up. For our French-speaking community, members across the country who wish to participate in a breakout room discussion in French, please feel free to select the Quebec French room, no matter where you are in the country. If you prefer French, that's where we'd welcome you to go. Once you see the groups on your screen, please choose your group, click join button on the right. If at any point you need to leave the room, simply close the room and/or the meeting. And we will go from there, and I will see faces shortly. Dr. Wong, I'm going to actually have you join a breakout room as well. And if you don't mind, would you mind joining Alberta first? And from there, Carrie will move you on to the next room, as I know that there are different, there'll be different questions throughout all of them. So everyone, please keep in mind that it's an allocated time that Dr. Wong will spend in each breakout room. But Dr. Wong, please select Alberta for now. I would greatly appreciate that. And we'll just go down the list from there. We'll see you all shortly.
While everybody comes back to the group, we have a few folks from the Quebec group where Dr. Wong is currently chatting with. Hope some of those discussions were very insightful. We greatly appreciate Dr. Wong being able to stick around for the extra half hour there. I know your time is pretty valuable, and we greatly appreciate that. So thank you for that. And hopefully some of the questions that we had in these discussion groups were helpful for folks. So I'll let Bianca take it away, and she'll close it off, and go from there.
So a quick message from Carol. She apologizes greatly. Technology is not her strong suit. She does have something really beautiful to share with everybody. So her and I are going to make arrangements to share her story, her journey with all of you. And we will make sure that we take care of that so you're able to find that. I just want to say thank you everyone for participating today in the peer-to-peer breakout rooms. Excuse me, it was extremely insightful. Before we conclude, I do want to mention that there will be a post-session survey evaluation available at the end of this session. It will automatically open in a separate window once this meeting is over. We will also be sending a survey link to all registrants in case you do not have the time to complete the survey following this session. I want to thank you all for attending today's Living with Liver Disease session on autoimmune liver disease. Should you have any additional questions or comments, or simply want to stay up to date on everything liver health related, please contact us via our social media channels highlighted on the screen, or you can send us an email to clf@liver.ca. Thank you to our sponsors. And of course, a big thank you for all of those who attended tonight's session. I really hope that you have a great evening. And thank you again for being a part of the session with us today.